good morning, respected emeritus chairman and founder of Mahatma Gandhi University of Medical Sciences and Technology, Dr. M.L. Swarkar sir, chairperson cum chancellor Dr. Vikas Chandra Swarkar, vice chancellor Dr. Ajay Gulati, pro-vice chancellor Dr. V.K. Kapoor, principal Mahatma Gandhi Medical College and Hospital Dr. M.V. Soni, senior faculty members, colleagues and dear students. I welcome you all to the 23rd Undergraduate Combined Rounds. The topic for today is urinary tract infections. The chairpersons for today's session are Dr. Pankaj Kumar Singh, Professor and Head Department of Anatomy, Dr. Puneet Rijwani, Professor and Head Department of General Medicine, and Dr. Anusha Vora, Professor and Head Department of Pharmacology. As we commence this session, I would like to invite Dr. Manish Gupta, Professor and Unit Head, Department of Urology, for his expert views on urinary tract infection. Sir.
Namaskar and very good morning to Emeritus Chairperson Professor M.L. Swarkar sir, other respected dignitaries on the present over here, convener UGCR program Dr. Ureters sir. I have been assigned today's very important and relevant topic to introduce this topic to all of you, urinary tract infection. So, with the introduction, urinary tract includes kidney, ureter, bladder, urethra. It is lined by urothelium, which is a protective barrier. It is usually sterile, and the defense mechanism of the urinary tract is by continuous urine flow and epithelial cell shedding, continuous epithelial cell shedding. Vesicular anti-reflux mechanism given to us and by the local immunity. A urinary tract infection occurs when microorganisms colonize and invade any part of the system. Then the burden of disease is common worldwide infection. It's a common worldwide infection. 50 to 80% women experience more than once UTI in her lifetime. Leading cause of outpatient antibiotic use. It's a major health care burden, hospitalized and catheterized patient. It emphasizes the need for proper classification and prevention. The general classification of UTI is, it is classified anatomically and clinically as upper tract UTI, which is more severe, systemic, leads to systemic complications also. It involves renal pelvis and parenchyma, causing acute pyelitis, acute pyelonephritis, and the lower urinary tract infections, which involves structures below the ureters like bladder, prostate, and urethra, leading to cystitis, prostatitis, and urethritis. Under clinical classification, it is divided into complicated and uncomplicated. Uncomplicated when the urinary tract is normal, and it usually occurs in healthy, non-pregnant women and other individuals. And complicated UTI is when there is structural functional abnormality in male, pregnant women, comorbidity, obstruction, catheter. Then recurrent UTI is more than 2 to 6 or more than 3 per year. Then the other classification is asymptomatic bacteriuria when the colony count is up to 10 raised to the 5 colony counts in the without symptoms. Catheter-induced UTI is common healthcare associated infection and indwelling urinary catheter, usually more than 48 hours. With clinical presentation, UTI presents in upper urinary tract infection, leads to pyelonephritis, which gives symptoms of high fever, high-grade fever, flying pain, renal tenderness, systemic toxicity. Lower urinary tract symptoms also gives symptom of fever, dysuria, frequency, urgency, and suprapubic pain. Common urinary tract infection is common but clinically significant across all age groups. The spectrum includes simple cystitis to pyelonephritis to septic shock. This is the most important presentation when the patient comes to us in the clinic with septic shock, and it's a grave emergency. We have to take care of this segment particularly. The early diagnosis depends upon understanding of the risk factors, classification, special population like pregnancy, catheterized patient, or TB-related patients. The timely management prevents serious complications. Now, with this introduction, I call upon the next speaker to give more insight about the UTI. Thank you.
Good morning, everyone, esteemed dignitaries, respected faculty and seniors, and my fellow classmates. I am Shubbangi, and I will be presenting the gross anatomy of the urinary system. This presentation is prepared with the help of my classmates, Kashvi Sharma, Tanu Agarwal, Priyansha Jain, Priyanshi Andana, and myself, Shubhangi. It was prepared under the guidance of Dr. Pankaj Kumar Singh, Professor and Head of the Department of Anatomy, and under the moderatorship of Dr. Pooja Garg, Assistant Professor of the Department of Anatomy. Now let's take a look at the learning objectives of this session. We'll be discussing the parts of the urinary system and their development. We'll also look at the gross anatomy of the kidneys, ureters, urinary bladder, and the urethra. We'll identify differences between the male and female urethra and discuss some clinical correlations. The urinary system has been divided into two parts: an upper urinary tract, which is made up of the kidneys and the ureters, and a lower urinary tract, which is made up of the bladder and the urethra. Now let's take a look at the development of the urinary system. The kidneys develop from the urogenital ridge, which forms the pronephros, mesonephros, and metanephros. The pronephros degenerate, whereas the mesonephros, it forms the mesonephric duct, which then continues as the ureteric bud. This ureteric bud then gives rise to the ureter and also the collecting part of the kidneys. Whereas the metanephric blastema, this forms the secretory part of the kidney. The bladder forms from the cloaca, and it forms in the 4th to 7th week of development, where the urorectal septum divides it into an anterior urogenital sinus, which then forms the bladder. But the trigone area in the bladder is formed by the absorption of the mesonephric duct. Now let's take a look at the external features of the kidneys. The kidneys are paired, bean-shaped retroperitoneal organs, and they lie in the vertebral level of the 12th thoracic vertebrae and the 3rd lumbar vertebrae. They have a superior pole, an inferior pole, an anterior surface, and a posterior surface. They also have a convexo-concave medial border and a convex lateral border. The medial border has a hilum, which has structures from anterior to posterior, which are the renal vein, the renal artery, and the renal pelvis. Now let's discuss the average dimensions of the kidney. The kidney has an average length of 11 centimeters, an average breadth of 6 centimeters, and an antero-posterior diameter of 3 centimeters. The average weight of kidneys in males is 150 grams, whereas in females it's slightly lower at 135 grams. The internal structure of the kidneys have been divided into two zones: the outer cortex and the inner medulla. The cortex has cortical caps over the medullary pyramids and renal columns between two adjacent medullary pyramids. Whereas the medulla has 5 to 10 conical masses called medullary pyramids, and the apices of these medullary pyramids form the minor calyces. These minor calyces then join together and form the major calyces. The major calyces connect together to form the renal pelvis, which narrows as the urethra. The functional unit of kidneys are the nephrons, which are made up of the renal corpuscles and the tubular part. From these, the renal corpuscle, the PCT and DCT lie in the cortical area, whereas the loop of Henle and the collecting duct goes into the medulla. In the microscopic slide, you can see these are the renal corpuscles, these are the glomerular capillaries, and the outer covering is the Bowman's capsule, whereas these circular structures are your tubules. Now let's take a look at the relations of the kidney. Anteriorly, the right kidney has relations with the suprarenal gland, the liver, the duodenum, jejunum, and the hepatic section. Whereas the left kidney has relations with the suprarenal gland, here, the stomach, spleen, pancreas, colon, and jejunum. Posteriorly, both kidneys have relations with the diaphragm, and from medial to lateral, they have relations with the psoas major, the quadratus lumborum, and the transverse abdominis muscles. Both kidneys also have relations with the subcostal nerves and vessels, and the inner hypogastric nerve and ilioinguinal nerve. The right kidney has relations with the 12th rib, whereas the left kidney also has posterior relations with the 11th rib, because the left kidney is slightly longer than the right kidney. The kidneys are covered by 4 layers. From inner to outer, these layers are the renal capsule or the true capsule, followed by the perirenal or perinephric fat, followed by renal fascia, which is also called false capsule. This renal fascia also covers the suprarenal gland superiorly. And it is open, it has two layers which don't join in the inferior aspect, and this helps to drain fluid from the kidneys. The last layer is the pararenal or paranephric fat. Now let's discuss the vascular supply of the kidneys. Each kidney is supplied by a singular renal artery, which then divides to form 5 segmental arteries. Out of these, 4 segmental arteries are in the anterior aspect, whereas 1 goes in the posterior aspect. And at the junction of these anterior and posterior aspects, there is a avascular plane, which is called the bloodless line of Brody. This is a suitable site for incision during surgeries. Also, these segmental branches form lobar arteries, which then divide to form interlobar arteries. And these form arches over the medullary pyramids and are called arcuate arteries. These arcuate arteries further give rise to interlobular arteries, and the interlobular arteries give rise to vasa recta and peritubular capillary networks. The nervous supply of the kidneys is done by the sympathetic fibers from T10 to L1, and the parasympathetic supply is done by the vagus nerve. An inflammation of the kidneys is called pyelonephritis, where the pyelo stands for the pelvic region, and this usually affects the renal pelvis and the renal parenchyma. Renal calculi or kidney stones are accumulation of minerals and salts such as calcium oxalate, phosphate, etc. because they have concentrated urine for a long period of time, and these salts get accumulated to form kidney stones. And these kidney stones also trap bacteria, which causes UTIs in the kidneys. Now let's move on to the next organ, which are the ureters. Ureters are narrow muscular tubes which have a length of 25 to 30 centimeters and a diameter of 3 millimeters. They present 5 normal constrictions, which are: the first one is at the pelvic junction here. The second one is at the point where the common iliac artery crosses the ureter. The third one is at the point where vas deferens crosses the ureter in males and where broad ligament crosses the ureter in females. The fourth point is at the uretrovesical junction here in the oblique passage. And the final constriction is at the ureteric orifice. The ureter has been divided into 2 parts, an abdominal part and a pelvic part. This is divided at the point where the common iliac artery crosses the ureter. And the relations of the abdominal part, in both ureters, there is a relation with the right conic vessels and the gonadal vessels. Whereas the right ureter also has additional relations with the duodenum, the endoconic vessels, and the root of mesentery. The left ureter also has relations with the sigmoid vessels and the sigmoid mesoderm. In the pelvic area, the ureter has relations with the common iliac artery, the internal iliac artery, and the bladder. In males, there is an additional relation with the vas deferens which crosses the ureter superiorly, whereas in females, the uterine artery crosses the ureter superiorly from lateral to medial side, and there is also a uterus present anteriorly. Now let's take a look at the vascular supply of the ureters. The ureters, along with the kidneys, ascend from the iliac fossa to the present location, and thus they have a variety of arteries supplying them. These arteries include the renal artery, the gonadal artery, direct branches from the abdominal aorta, direct branches from common iliac artery, and internal iliac artery. And they also have branches from the uterine artery and the vesical arteries. The venous drainage of the ureter follows a similar pattern. The vessels that supply the ureter are closely attached to the peritoneum, so it's advised that we do not detach the ureter from the peritoneum during surgeries. An inflammation of the ureter is called ureteritis, and ureteral calculi, which usually form in the kidney, have a tendency to get lodged in the normal restrictions of the ureter. There they become a place where bacteria gets trapped and cause UTIs in the ureter. Now let's move on to the next organ, which is a hollow muscular organ called urinary bladder. It has an average capacity of 300 to 500 milliliters, and it lies in the pelvic area. But when full, it can extend into the abdomen, even above the umbilicus. But in children, however, it is an abdominopelvic organ usually, because children have a smaller pelvic cavity. The urinary bladder has a base or fundus, a body, an apex, and a neck. The internal features of the urinary bladder include a transitional epithelium and rugae, which are folds of the mucosal wall. These folds of the mucosal wall are absent in the trigone area, and therefore it appears smoother, and it also has 2 urethral orifices and a urethral orifice here. Now let's take a look at the relations of the urinary bladder. The urinary bladder, both in females and males, the urinary bladder has an interior relation with the pubic symphysis and the retropubic area here. And it has a superior relation with the coils of the small intestine and a posterior relation with the rectum. In males, there's an additional relation inferiorly with the prostate gland and the penis, and here there's an area called the rectovesical pouch. In females, there's an additional relation with the uterus, which is present superior posteriorly, and a posterior relation with the vagina here. There's also the presence of a vesico-uterine pouch here. The arterial supply of the bladder is done by superior vesical artery and inferior vesical artery. This is accompanied by the vaginal artery in females. The venous drainage of the urinary bladder is done by the side of venous plexus, and the lymphatic drainage is done by external iliac veins. The nervous supply of the bladder is very important, and it is done by the sympathetic fibers from T11 to L2 and parasympathetic fibers from S2 to S4. The sympathetic fibers aid in the filling of the bladder, whereas the parasympathetic fibers help in the emptying of the bladder. There's also a somatic supply which helps in the voluntary control of micturition. Neurogenic bladder is a condition that occurs when any of the nerves supplying the bladder are damaged. Examples of this could be automatic bladder or autonomous bladder. Automatic bladder occurs when nerve supply above the S2 to S4 are affected, and this causes the loss of the voluntary control of micturition. Whereas autonomous bladder occurs when S2 and S4 are also affected, and this not only causes a voluntary loss of the micturition, but it also causes a flaccid bladder, which causes continuous leaking of urine, and there's a requirement for catheterization. An infection of the bladder is called cystitis, and usually in older males, the prostate gets enlarged. So it constricts the urethra, and therefore the bladder has prolonged time of urine storage. This makes it a place where bacteria can harbor and cause urinary tract infections in the bladder. The last organ of the urinary system is the urethra. In males, the urethra has a length of 20 centimeters and is divided into the preprostatic part, the prostatic part, the membranous part, and the penile or spongy part, and finally the narrowest part, which is the external urethral orifice. The female urethra is 4 centimeters long and much shorter, and it opens into the vestibule close to the anterior vaginal wall. Females are much more likely to experience UTIs because their urinary tract urethra is shorter, and therefore any infection can travel up to the upper urinary tract. Also, female urethra is closely in proximity with the anus and the vagina, and from there the digestive tract bacteria can travel to the urethra and cause UTIs. Urethral catheterization is a process where a narrow rubber tube is inserted into the urethra and the bladder for urinary discharge. If this procedure is done incorrectly, or if the catheter is not sterilized properly, it can cause a risk of the catheter-associated urinary tract infections, or CA-UTIs. These are the references we used in the preparation of this presentation. And now I would like to request the next department, which is physiology, to take over.
Hold on. You are an MD student in anatomy, but you have the confidence of a postgraduate. Stay on. You said the left kidney is in contact with the 11th rib because it is longer. I don't think that is correct. It is because it is higher. The liver displaces the right kidney down. Both kidneys are same size. Am I correct, Dr. Manish?
Yep.
Good, very good.
Good morning, esteemed dignitaries, respected faculty members, seniors, and my fellow batchmates. I am Janhavi Mathur from MBBS batch 2025, along with my team members Himansh Bishnoi, Lokesh Punia, Manas Raj Saini, and Rajat Sharma, who have contributed meaningfully in the preparation of this work. Under the guidance of Dr. Aparna Garg ma'am, Professor and Head, Department of Physiology, and under the moderationship of Dr. Rosie Paul ma'am, Assistant Professor, Department of Physiology. Let us look at the learning objectives of today's session. Now let's talk about nephron. It is the structural and functional unit of kidney. It is essentially a long specialized tube that interacts closely with a network of blood vessels. Each kidney contains 800,000 to 1.5 million nephrons. Nephrons can be classified into two types based on their location. That is, the cortical nephron and the juxtamedullary nephron. Cortical nephrons make up the majority of nephrons, that is 85% of the total nephrons. In them, the glomeruli is located in the outer cortex, and it helps in filtration and reabsorption. The juxtamedullary nephrons make up the rest 15% of the nephrons. Glomerulus is located deep in the renal cortex near the medulla. It helps in filtration, reabsorption, and creation of medullary osmolar gradient. Now when we see the diagram, we can see that the loop of Henle is short in the cortical nephrons and it only reaches the outer zone of the medulla, whereas it is long in the juxtamedullary nephron and it dips in the inner zone of the medulla. Also, the vasa recta is only present in the juxtamedullary nephrons but is absent in the cortical nephrons. Now let us look at the peculiarities of the renal blood flow. There is high magnitude of flow as the kidney receives 20 to 25% of the total cardiac output. There is autoregulation. Two distinct perfusion zones are present, that is the renal cortex and renal medulla. Medullary blood flow is extraordinarily low. It is only about 5 to 10% of the renal blood flow. It contains a portal system that connects two capillary beds, that is the peritubular capillary network and the glomerular capillaries. Low oxygen extraction and vasa recta, which is a continuation of the peritubular capillary network along with the loop of Henle in the medulla. Now let us move to the urine formation, which is today's topic. Urine formation is a complex, multi-stage physiological process performed by the kidneys to maintain the body's internal equilibrium, homeostasis. There are three steps in urine formation: glomerular filtration, tubular reabsorption, and tubular secretion. Glomerular filtration. It occurs at the renal corpuscle, which contains glomerulus and the Bowman's capsule. It is a passive process. Fluid and solute are forced out of the blood into the renal tubule system. It contains three layers, that is the fenestrated endothelium, the basement membrane, and the podocytes. Glomerular filtration rate, that is the GFR. The total volume of fluid filtered from the glomerular capillaries into the Bowman's capsule per unit time is the glomerular filtration rate. In the average adult human, the GFR is about 125 ml per minute or 180 liters per day. The composition of the filtrate includes urea, electrolytes, glucose, amino acids, and urea. The glomerular filtrate is devoid of plasma proteins because filtration barrier in the renal corpuscle is highly selective based on both size and electric charge. We have three types of filtration pressures operating here. The glomerular hydrostatic pressure is inside the glomerular capillaries, which favors the filtration process. It is about 60 mm of Hg. The glomerular colloid osmotic pressure, which is caused by the plasma proteins, mainly albumin, it opposes the filtration. It is 32 mm of Hg. And the Bowman's capsule pressure, which is about 18 mm of Hg, and it also opposes the filtration. When we cumulate all of them, we get the net filtration pressure as 10 mm of Hg. GFR is equal to Kf into net filtration pressure, where Kf is the filtration coefficient. It is a product of hydraulic conductivity and the surface area of the glomerular capillaries. It is about 12.5 ml per minute per mm of Hg. GFR can be measured by the plasma clearance test, inulin or creatinine. Now we talk about the hormonal regulation of GFR. Norepinephrine, epinephrine and endothelin constrict the renal blood vessels and decrease the GFR. Angiotensin II prevents the decrease in GFR as it constricts the efferent arterioles in most physiological conditions. Endothelial-derived nitric oxides, prostaglandins and bradykinin decrease the renal vascular resistance and increase GFR. They are the vasodilators. Now let's talk about tubular reabsorption. It includes passive and active mechanism. It is the second crucial step in urine formation where the nephron recovers 99% of water, electrolytes and nutrients from the filtrate, returning them to peritubular capillaries. It primarily occurs in the proximal convoluted tubule, about 65%, along with loop of Henle, distal convoluted tubule and collecting duct. Tubular secretion. It is the process by which materials are transferred from peritubular capillaries to the renal tubular lumen. It helps in the elimination of additional waste, maintain acid-base balance, and regulate the electrolyte levels. It mainly occurs in the distal convoluted tubule and collecting duct, but also partly in the proximal convoluted tubule. Now let's talk about proximal convoluted tubule, that is PCT. The proximal tubules reabsorb 65% of the filtered sodium, chloride, bicarbonate, potassium, and essentially all the filtered glucose and amino acids. It also secretes organic acids, hydrogen ions into the tubular lumen. Loop of Henle. It is made up of two parts. The thin descending loop of Henle. It is highly permeable to water and moderately permeable to most solutes, but has few mitochondria, so little or no active reabsorption takes place. And the thick ascending loop of Henle, which reabsorbs about 25% of filtered loads of sodium, chloride, and a large amount of calcium, bicarbonate, and magnesium. This segment secretes hydrogen ions into the tubular lumen. The distal convoluted tubule, DCT, reabsorbs sodium, chloride, calcium, and magnesium, but virtually impermeable to water and urea. The late distal tubule and cortical collecting tubules reabsorb sodium and bicarbonate and secrete potassium and hydrogen ions. The juxtaglomerular apparatus. It is made up of three types of cells: juxtaglomerular cells, macula densa cells, and the mesangial cells. The juxtaglomerular apparatus maintains homeostasis through two mechanisms: the RAS mechanism, which is the renin-angiotensin-aldosterone system, and the tubuloglomerular feedback. Collecting duct. The medullary collecting duct actively reabsorbs sodium and secretes hydrogen ions. These tubules are permeable to urea, which is reabsorbed in these segments. The reabsorption of water from this tubular segment is controlled by the concentration of antidiuretic hormone, ADH, which is also known as vasopressin. These are the applied physiology of urine formation. It includes removal of metabolic waste, acid-base regulation, concentration and dilution of urine in different environmental conditions, that is the countercurrent mechanism, and renal ion regulation. Micturition reflex. What is micturition? Micturition is the process by which the urinary bladder empties when it becomes filled. Micturition contractions are induced by a stretch receptor initiated by sensory stretch receptor in the bladder wall. Normal micturition typically involves voiding 150 ml to 400 ml of urine per session in adult. The maximum bladder capacity is around 400 to 500 ml. Cystometrogram. It is a graph that illustrates the relationship between the intravesical volume on the y-axis and the intravesical pressure on the x-axis as the bladder fills. Pressure peaks are called micturition waves caused by the micturition reflex. When we see the diagram, we can see that initially when there is no volume of urine in the bladder, the pressure is about 0. But then it increases to about 10 centimeters of H2O. Then it remains fixed at this volume. Even when the volume is increasing, it remains fixed at this pressure because of the intrinsic tone of the bladder. And then it shoots rapidly. Pressure peaks are called the micturition waves, which are caused by the micturition reflex. The micturition reflex, filling of urinary bladder occurs. Then there is stimulation of stretch receptors. Afferent impulses pass via the pelvic nerve to the sacral segments of spinal cord. Then the efferent impulses come via the pelvic nerve. There is contraction of detrusor muscle, which is the muscle of the bladder, and relaxation of the internal sphincter. Flow of urine into the urethra and stimulation of stretch receptors. Then again, afferent impulses come via the pelvic nerve. There is inhibition of pudendal nerve, which was controlling the external sphincter. So there is relaxation of external sphincter. Finally, voiding of urine occurs. The applied physiology includes atonic bladder, which is caused by destruction of the sensory nerve fibers S2 to S4. The person loses bladder control that results in overflow incontinence. Neurogenic bladder, which is caused by lack of inhibitory signals from brain due to lesion in brainstem. And automatic bladder, which is caused by the spinal cord injury above S2 to S4, but the sacral arc reflex remain intact. So there is hyperactive micturition and loss of voluntary control of micturition. These are the references which were used in making this presentation. I now request the microbiology department to proceed further.
Good morning, honorable dignitaries, esteemed faculties, dear colleagues, seniors and juniors. We are representing the Department of Microbiology in the 23rd Undergraduate Combined Rounds on the topic Etiology and Laboratory Testing in Urinary Tract Infection. This presentation is prepared by Muskan Banu, Neha Sharma, Parul Sonkaria, Yamini Yadav, and I, Vanshita Agarwal, students of MBBS Second Prof, under the guidance of Dr. Ved Prakash Mamoria, Professor and Head, Department of Microbiology, and under the moderatorship of Dr. Pradeep Kaur, Assistant Professor, Department of Microbiology. The learning objectives are etiology of UTI. The other section will involve laboratory diagnosis of UTI. Starting with the etiology of UTI. Basically, urinary tract infection is defined as a disease that is caused by invasion of microbes into the urinary tract that extends from the renal cortex of kidney to the urethral ureters. There are two bases onto which UTI is classified. First, based on the anatomical side, it is classified into lower UTI, which includes bladder and urethra, and upper UTI, which includes kidney and ureter. Based on the source of infection, it is classified into healthcare-associated UTI, for example, catheter-associated UTI, and community-acquired UTI. There are various etiological agents responsible for causing UTI, among which the predominant ones are the bacterial agents. The commonest among them are gram-negative bacilli, for example, Escherichia coli, which is responsible for about 70% cases of UTI, and other pathogens like Klebsiella pneumoniae, Proteus mirabilis, gram-positive bacilli like Mycobacterium tuberculosis, and gram-positive cocci like Staphylococcus saprophyticus and Staphylococcus aureus. Other than these, some other agents are also responsible for causing UTI, which include fungus like Candida albicans, parasites like Trichomonas vaginalis, and viruses like adenovirus types 11 and 21. Now we shall start with the laboratory diagnosis of urinary tract infection. Before we proceed further, it is necessary to know the importance of lab diagnosis in the case of urinary tract infection. It confirms the presence of infection, differentiates contamination from a true infection, identifies the causative organism and determines the sensitivity of antibiotics, prevents complications such as pyelonephritis and sepsis, and is important in the detection of bacteriuria. The major requirement for urine sample is an ideal container, which should be wide-mouthed, sterile, screw-capped, and leak-proof. It should be properly labeled with the contents like patient name, age, sex, IPOP number, date, and time of collection. A test requisition form, as shown here, is a critical document used by healthcare providers to order lab diagnosis for infectious diseases. It should mention clinical diagnosis and antibiotic history of the patient. The preferred time of collection is early morning midstream urine before starting the antibiotics. The collection methods vary greatly among the genders. An ideal sample is a midstream clean catch urine known as MSU, as it reduces contamination from the skin fluid. In females, the procedure involves washing the hands, clean periurethral area with soap and water, separate labia and discard first part of the urine, and collect midstream urine of 20 to 30 ml volume. The precautionary measure to take here is not to touch the rim of the container. In males, wash the hands, retract foreskin, clean glans penis, discard initial stream, and collect midstream urine. In catheterized patients, some precautions one has to take are never collect from urine bag, clamp the catheter, clean sampling port with spirit, aspirate urine using sterile syringe, and transfer it to a sterile container. This figure here shows the process by which urine sample collection is done in catheterized patients. It shows the bladder where the urine is stored. This shows balloon inflation port in which the balloon is inflated using sterile water. Then the suprapubic catheter, which is inserted directly into the bladder by piercing the abdominal wall. This clamp is applied to stop the urine flow, and this sampling port is used to withdraw the urine by a needleless syringe which aspirates the urine. Methods of urine collection in infants can range from clean catch urine and catheterization to suprapubic aspiration, which is the most sterile method. One of the major techniques to discuss here is finger tap bladder stimulation technique, based on the principle that gentle tapping above the pubic symphysis stimulates bladder reflex, leading to voiding of urine by the infant. The specimen collected should be immediately transported to lab within a range of 1 to 2 hours. In case there is no delay, the specimen undergoes direct processing in laboratory for specimen verification.
In case delays are expected, the specimen is stored using boric acid at the required temperature and then delivered to lab after safe packaging. Direct examination can be conducted in two ways. Macroscopic examination, which includes color, which is pale yellow in normal conditions and becomes cloudy and dark yellow in UTI. Turbidity, also known as clarity, is clear under normal conditions and becomes turbid or cloudy due to presence of pus cells and bacteria in UTI. Odor is mild under normal conditions, which progresses to foul smelling in UTI. In macroscopic examination, the urine is centrifuged at the rate of 1500 to 3000 revolutions per minute for 5 minutes. Then the wet mount preparation of the sediment is examined under low power and high power fluid. Pus cells, if more than 10 per high power fluid, are considered as significant findings. Routine examination of urine can be broadly classified into physical examination and chemical examination. The physical examination includes volume of the urine, which is increased in diabetes mellitus, known as polyuria, and decreased in dehydration, known as oliguria. The color, which is normally pale yellow, becomes red in hematuria and milky in pus or pyuria. The appearance is normal, which becomes turbid due to infection of pus cells. Specific gravity is increased in dehydration and decreased in renal failure. Chemical examination, which is done by dipstick method, can result in the following findings like protein, ketone bodies, bile salts and pigments, leukocyte esteries. Moving on to the culture technique significant in the case of UTI. The sample is inoculated on culture media, which is cystine lactase electrolyte deficient agar shown here, or sheep blood agar and McConkey agar in combination with blood agar using a calibrated urine loop for semi-quantitative estimation. The obtained inoculated plate are then incubated at 37 degrees in an incubator for a range of 18 to 24 hours and then examined for growth. The method of treating with urine loop involves loop is touched to the center of the plate from which the inoculum is spread in a line across the diameter of the plate. Loop is drawn across the entire plate, crossing the first inoculum streak numerous times to produce a number of isolated colonies. Moving on to the CAST concept of significant bacteriuria, this concept was established by Edward H. Cass in 1950s. It defines significant bacteriuria as bacterial count of more than or equal to 10 to the power 5 colony-forming unit per milliliter of urine to distinguish true urinary tract infection from a contamination. The interpretations are as follows. If more than or equal to 10 to the power 5 CFU per ml the colony count is, it results in significant bacteriuria resulting UTI certain. 1000 to 1 lakh CFU per ml interprets probably significant bacteriuria, in which case UTI is probable, and less than 10 to the power 3 CFU per ml results in insignificant bacteriuria, in which UTI is unlikely. One of the things to test here is colony appearance, in which color, odor, emulsifiability, shape and size are some of the identifying characters. The last step in the laboratory diagnosis of urinary tract infection is result reporting. Antimicrobial susceptibility test, abbreviated as AST, of obtained growth is done, followed by reporting. The three cases here are when no growth is obtained after 24 hours of incubation, it is resulted as no growth obtained on culture after 24 hours of incubation. When there is growth of 3 or more organisms, it is resulted as polymicrobial flora grown on the culture. When contaminants like diphtheroid and coagulase negative staphylococci are grown on culture media, it is reported as contaminants grown on culture. Antimicrobial susceptibility test is important to select effective antibiotics and prevent resistance in the case of urinary tract infection. These are the references used for the preparation of this PPT. Thank you everyone. Now I would like to call the Department of Pathology.
24. I'm here to present on the topic pathological changes in the urinary tract infection. This PPT has been prepared by my batchmates, Janhavi Mathur, Shreyansh Gautam, Suhani Bansal, Ujjwal Jandu and myself under the guidance of Dr. Manjula Agarwal, Professor and Head Department of Pathology, and moderated by Dr. Vanshita Agarwal, Assistant Professor, Department of Pathology. Now, as discussed earlier, these are the learning objectives. As discussed earlier, the urinary system consists of kidneys, ureters, urinary bladder, and urethra. This has also been discussed earlier that the urinary tract infection is defined as an infection of any part of the urinary tract, whether it is urethra, bladder, ureter, or kidney. The predisposing factors of UTI include the bacterial infection, poor hygiene, urinary stasis, catheterization, sexual activity, and pregnancy and diabetes. Females have more chances of UTI as compared to males due to short urethra, close proximity to anus, lack of the prostatic secretions, and hormonal influence. Now, the urinary tract infection is further classified into lower tract UTI and upper tract UTI on the basis of anatomy. Lower tract UTI consists of cystitis, urethritis, and prostatitis, and upper tract UTI consists of pyelonephritis and renal abscess. Now, the pathogenesis of urinary tract infection, it occurs by two routes, ascending infection and hematogenous infection. The most common route is ascending infection, and it is most commonly caused by the bacteria Escherichia coli. Now, these are the steps of ascending infection. First, there is periurethral colonization by the gut flora. Then the bacteria arise into the urethra and attach to the uroepithelial cells with the help of fimbriae. When there is instrumentation like catheterization, the bacteria may reach into the urinary bladder. When there is obstruction or urinary stasis, the bacteria may multiply rapidly. Then the host starts to show inflammatory response, which includes neutrophilic infiltration, cytokine release, and mucosal edema. The clinical features of cystitis, like increased frequency of urination, urgency to urinate, and painful urination, starts to show. The further bacteria may rise into the kidney via the ureters, leading to pyelonephritis. Now we come to acute cystitis. In gross pathology, we see edematous mucosa, and there is also the presence of exudate. In microscopic features, we see mucosal edema and neutrophilic infiltration of whole mucosa. Now, pyelonephritis. It is further classified into acute pyelonephritis and chronic pyelonephritis. Acute pyelonephritis is the acute suppurative inflammation of the kidney caused by the pyogenic bacteria, and chronic pyelonephritis is the chronic tubulointerstitial disease resulting from repeated attacks of inflammation and scarring. Now, acute pyelonephritis, in gross pathology, we see enlarged and edematous kidney and multiple small yellowish abscesses on the cortical surface. In microscopic features, we can clearly see in the image that there is neutrophilic infiltration in interstitium and tubules, interstitial edema, there is pus cast or WBC cast, and tubular necrosis or destruction, and there is most importantly relative sparing of the glomeruli. Now we come to chronic pyelonephritis. In gross pathology, we see asymmetrical kidney shrinkage, irregular cortical scarring, dilated and deformed renal pelvises and calyces, and thinning of the renal parenchyma. In microscopic, we clearly see interstitial fibrosis, chronic inflammatory cell infiltration, thyroidization of the tubules, atrophic tubules, and periglomerular fibrosis and hyalinization. In laboratory diagnosis, as explained earlier, we regularly do urine routine examination, which is the basic urine test. Whenever they did UTI, it shows bacteriuria, which is the presence of bacteria, pyuria, which is the presence of pus cells in urine, and WBC casts are also present. Further, we do urine culture, which is considered as a gold standard test for diagnosis of urinary tract infection. Ultrasound detects the enlargement and cortical scarring, obstruction, etc. And CT scan detects the renal abscess. Now we come to the complications of UTI. First of all, it may lead to perinephric abscess. When there is suppurative inflammation extending through renal capsule into the perinephric tissue. Second is papillary necrosis, which occurs most commonly in diabetic patients and sickle cell disease. Grossly, in it we see yellow to grey white necrotic papilla. In pyonephrosis, we see suppurative exudate unable to drain. Then it fills the renal pelvises and calyces and ureter with pus. In chronic kidney damage, the chronic pyelonephritis leads to progressive renal insufficiency, which further leads to chronic kidney damage. These are the references. Now I would like to invite my colleague from Department of Pharmacology.
I am Manish Gupta from batch of 2024, along with my team members Anushka Sharma, Harshita Sharma, Sumani Yadav, Tamesh Sharma. We are pleased to present on the topic pharmacotherapy of urinary tract infection, or commonly known as UTI, under guidance of Dr. Shubbangi, Professor Head of Department of Pharmacology, moderated by Dr. Ravi Kumar, Assistant Professor, Dr. Harshal Patil from Department of Pharmacology. These are the learning objectives we will be covering today. Further moving on to this topic, I would like to give you a brief explanation
about urinary tract infection. It is one of the most common type of bacterial infection, commonly affecting urethra, urinary bladder, ureters, and kidney. UTI affecting urinary bladder is commonly known as cystitis, while in kidney is known as pyelonephritis. From the word treatment, the first thing which comes up to your mind is why do we need treatment? UTI can cause serious distress including burning micturition, suprapubic pain, including flank pain, back pain, frequency and urgency in urination. To eradicate the causative organism and prevent ascending infection, infection from lower urinary tract can ascend upward and affect kidney, causing acute pyelonephritis, which is more severe and life-threatening. Antibiotic therapy is provided for the same, prevent complications like pyelonephritis, sepsis, renal damage or scarring, renal abscesses, prevent mortality and morbidity, especially in vulnerable populations like pregnant women, children, elderly patients, patients with diabetic mellitus, prevent antibiotic resistance through appropriate therapy. Choice of antibiotics depends upon site of infection, predisposing factors like pregnancy, diabetes, whether the organism is drug resistant or drug sensitive. Now we will be discussing about management of uncomplicated lower urinary tract infection with its empirical therapy. It commonly occurs in healthy individuals without no structural and functional abnormalities in urinary tract. The most common causative agent is E. coli in approximately 80 to 90% of cases. A short-term oral therapy is given for 3 to 5 days. First-line drugs are used including nitrofurantoin, trimethoprim, sulfamethoxazole. Alternative options are fluoroquinolones, amoxicillin, clavulanic acid, third-generation cephalosporins. Now the management of complicated urinary tract infections, specifically for mild to moderate pyelonephritis. Unlike uncomplicated UTI, renal structure and functional abnormalities are present in this. Again, the most common causative agent is E. coli for 60 to 70% of cases. As infection is more severe, empirical therapy is given in form of injectable drugs initially, including aminoglycosides like gentamicin, amikacin with or without ampicillin, third and fourth generation cephalosporin like ceftriaxone, cefepime, fluoroquinolones like levofloxacin, norfloxacin, piperacillin, tazobactam, carbapenems for resistant organisms. These are the most important antibiotics used in urinary tract infection. We will be discussing drugs, its mode of action, spectrum and adverse reaction. First is nitrofurantoin. It is a first-line drug in case of uncomplicated UTI. It acts by forming reactive intermediates by bacterial nitroreductase enzyme and damaging bacterial DNA and protein. It is not effective against organisms such as Pseudomonas aeruginosa and most upper UTI pathogens. Adverse reaction including pulmonary toxicity and peripheral neuropathy. Next is cotrimoxazole. It is a combination of trimethoprim and sulfamethoxazole. It acts by sequential blockage of foliate synthesis, reducing the bacterial growth. It is not effective again on Pseudomonas aeruginosa and Enterococcus faecalis. Adverse reaction including rashes, photosensitivity, and bone marrow compression leading to anemia, leukopenia, and thrombocytopenia. Next is fluoroquinolones like levofloxacin, ceprofloxacin. It acts by inhibiting bacterial DNA synthesis and also inhibiting type 2 and 4 topoisomerase. It is not effective against anaerobes and some resistant strains. Adverse reaction including tendinitis, photosensitivity, and confusions. Next is amoxicillin clavulanic acid. It acts by inhibiting cell wall synthesis, and clavulanic acid protects enzymatic degradation by inhibiting beta lactamase. It is not effective against Pseudomonas aeruginosa and some multiple drug-resistant gram-negative bacteria. Common adverse reactions are cholestatic hepatitis and hypersensitivity. Last is third-generation cephalosporin, such as ceftriaxone, inhibits bacterial cell wall synthesis. It is not effective against methicillin-resistant Staphylococcus aureus and extended spectrum beta-lactamase producing organism. Adverse reaction including nausea, hypersensitivity, and hemolytic anemia. Symptomatic treatment. Symptomatic treatment aims at relieving symptoms rather than actually killing the bad bacteria. First is analgesics to relieve pain like penazopyridine, ibuprofen, acetaminophen. Second is urinary alkalizers for burning micturition and to increase pH. Third is adequate hydration to flush out bacteria from urinary tract. Severe hospitalized extended spectrum beta lactamase. Most common pathogens are E. coli, extended spectrum beta lactamase producers, Klebsiella pneumonia, multi-drug resistant, Pseudomonas aeruginosa, Candida species if immunocompromised. The most commonly used antibiotics are carbapenems, first-line drugs such as meropenems and imipenems, cefepime with aminoglycosides, colistin combinations. Now we will be discussing about some special cases in urinary tract infection. First is urinary tract infection in case of pregnancy can lead to severe complications like preterm labor or pyelonephritis and require prompt treatment. These are some safely used drugs in case of pregnancy, which are cephalosporin for second, third generation, amoxicillin clavulanic acid, amoxicillin nitrofurantoin monohydrate, except neoderms. Drugs to be avoided in pregnancy to protect from fetal toxicity are fluoroquinolones, dimethylprime sulfamethoxazole, tetracycline, aminoglycosides. UTI in case of diabetes is most common and severe because increase in blood sugar leads to increase in bacterial growth and reduced immunity. Commonly used drugs are fluoroquinolones, nitrofurantoin and fosfomycin. UTI in case of catheterized patients, first-line oral agents used are nitrofurantoin, trimethylprime sulfamethoxazole, cephalosporin, amoxiclavulanic acid, amoxicillin clavulanic acid. Acute bacterial prostatitis. Commonly used antibiotics are fluoroquinolones like ciprofloxacin, levofloxacin are first line of treatment. Other option includes trimethylprime sulfamethoxazole is also used. Asymptomatic bacteriuria is increasing concentration of bacteria in urine without symptoms is generally does not require treatment except in case of pregnancy. Recurrent UTI, it occurs in 3 or more episodes per year. It is most common in sexually active females. Management including long-term prophylaxis with nitrofurantoin, behavioral modifications with antimicrobial prophylaxis to drink plenty of water, not to control urge to pass urine, to empty the bladder completely and very often, to empty the bladder after sexual intercourse, wipe front to back during ablution, duration for 6 to 12 months. UTI in case of children leads to complications like renal damage or scarring. In case of uncomplicated, oral therapy can be given of cephalosporin or amoxicillin clavulanic acid for the duration of 3 days. And in case of complicated upper urinary tract infection, initially intravenous or intramuscular therapy is given of cephalosporin with amoxicillin clavulanic acid or fluoroquinolones for the duration of 7 to 14 days. New antimicrobials, these are some antibiotics introduced to increase the efficiency of pharmacotherapy of urinary tract infections. Drugs including ceftazidime avibactam from the class of beta-lactam. It is effective against the extended spectrum beta-lactamase organisms and AMPC carbapenems resistant gram-negative bacteria. Meropenems avibactam from the class of carbapenems, effective against carbapenems resistant enterobacteriaceae. Last is plasmicin, is from the class of aminoglycosides. It is effective against multi-drug resistant gram-negative bacteria. Above 2 are FDA approved, while the third one is under investigation. This is the key summary for the presentation. Nitrofurantoin only for lower UTI and cystitis, which is in case of urinary bladder. Pyelonephritis needs tissue penetrating antibiotics. Complicated UTI always in urine for culture. Uncomplicated UTI prefers short course therapy. Extended spectrum beta lactamase organisms treat with carbapenems. Fluoroquinolones avoid in pregnancy. Fosfomycin useful in multi-drug resistant urinary tract infection. Recurrent urinary tract infections consider prophylactic antibiotics. This is the references for the presentation. Now I would like to invite Greater Department for
You need a culture for all UTIs. It's not just for complicated UTI. And secondly, remember to send a culture sample before you start the antibiotic. All right.
I have a few comments because this is a technical topic. So, duration of antibiotics in recurrent and complicated UTI, that is important to mention. And it is usually a longer duration, 1 to 2 weeks. And I would also wish that you had covered urinary tract infection in patients with decreased urine clearance. Which are the drugs which are safe and how do you dose modify the drugs, right?
yes.
Good morning everyone. My name is Diva Paliwal from batch 2022 and I am here to present on the topic Imaging in Urinary Tract Infection. This presentation was made by Manish Saraswat, Krishna Bharkar, Radhika Singh, Tejas Mehta and myself under the guidance of Dr. Paresh Kumar Sukhani and moderatorship of Dr. Agarwal. As we all know, UTI is a clinical diagnosis. It is confirmed by urine analysis and culture. Imaging is not part of the routine management. However, it is indicated in specific clinical situations which we will discuss later. The role of radiology is that it helps us figure out the site of infection, severity of involvement, underlying causes of UTI, that can be stones or obstructions, complications of UTI, and causes of recurrent UTI. The indications of UTI indications of UTI are, it can be done when complicated UTI is suspected, which is seen in diabetic patients or immunocompromised patients, or when fever is persistent even after giving antibiotics for more than 72 hours. It is also done in recurrent or atypical UTI, which is seen in male patients. Pediatric UTI is a special case in which we do radiological findings even on the first febrile case. This slide here classifies UTI based on anatomical site, obstructive conditions, and iatrogenic causes. Coming on to the first major upper urinary tract infection, that is acute pyelonephritis. Acute pyelonephritis is the infection of renal pelvis, calyces, and the parenchyma. If severe, it can lead to some major complications, which we will discuss later. On USG, which is the first-line modality of choice, as it is present very easily, it can be done bedside, and it has no harm to radiation. USG findings of kidney, ureter, and bladder system, we see renal enlargement, loss of corticomedullary differentiation due to edema, and CT is the main choice, as we can differentiate between hematogenous pyelonephritis and ascending pyelonephritis. On hematogenous pyelonephritis, we see lesions in the cortical area as the infection is spreading via the blood vessels, and the blood vessels are ending in the cortical area. On ascending pyelonephritis, the infection spreads via the urothelium. So we see linear wedge-shaped hypodense lesions which are non-enhancing on contrast CT, which is how we differentiate between ascending and hematogenous pyelonephritis. Coming on to the first complication of acute pyelonephritis, emphysematic pyelonephritis. It is commonly seen in diabetic patients due to the high glucose level in them. The bacteria forms gas, which on X-ray is seen as motile gas shadows over the renal area. On USG, we see hypoechoic focus of gas, which is bright focus due to the gas bubbles. CT is the gold standard as it gives us the exact location, accurately detects gas, And as we can see, the gas bubbles are present here and they have spread to the right psoas muscle, which helps us clarify them and detect the extent of infection. It also helps us guide the management. Renal abscess is collection of pus in a localized area, whereas acute pyelonephritis was a diffuse swelling. On UST, we see well-defined focal hypoechoic areas and internal echoes visualized due to the debris present in the abscess. CT is the gold standard as it gives us the exact location of the abscess and helps us plan a drainage. On CT, we see round hypodense lesions with the peripheral rim which is enhanced, that is, it is bright, the rim is bright and the central area is dark, non-enhanced due to the presence of liquefied matter present there. Perinephric abscess is seen secondary to the rupture of renal abscess or renal abscess. Contrast CT shows multi-ocular cystic lesions of the kidney extending to the posterior perirenal area involving the diaphragm and the posterior abdominal wall. Here we can see CT-guided percutaneous abscess drainage. Pyelonephrosis is a urological emergency. In this, pus accumulates in the collecting system leading to obstruction and ultimately hydronephrosis but infected. On UST, we see dilated pelvic calcium system due to the filling and obstruction. Along with that, we see a fluid level which is differentiation of fluids based on their densities. A heavier pus settles at the bottom and a lighter urine stays on the top. On CT, we see hydronephrosis, which is dilation of the pelvic calcium system, and it helps us rule out abscess as also visualize the underlying cause of obstruction, which could be stones. Urolithiasis is a common cause of UTI in patients. On X-ray, we can see radiopaque stones, which are calcium containing, but we can't see radiolucent stones, which are uric acid made. So it is not the gold standard. On UST, we see hypogenic focus, which is bright focus due to the stone presence, and behind it, a posterior acoustic dark shadow. A twinkling effect is seen on the color Doppler, which we can see here. And non-contrast CT is the gold standard because it can visualize all the stones, exact size and location can also be determined. Hypodense stones can be seen in exact size and location. CT can be the multi-vector CT is the normal CT that we do for planning and treatment, planning and monitoring the treatment success. Dual energy CT is a special CT that we do for detecting the stones based on their category, so we can plan the treatment accordingly. Benign prostatic hyperplasia is prostatomegaly is a common cause of UTI in elderly males. On UST, we see enlarged prostate and increased post-void residue. We can do another specific better assessment, that is transrectal ultrasound, in which the probe is inserted into the rectum to obtain a better diagnosis. Yes, sorry sir. Transrectal. In this, the probe is inserted into the rectum and we see enlarged rectum with enlarged transitional zone, which blocks the urethra and causes an obstruction leading to urinary tract infection. Imaging algorithm followed in pediatrics is different from normal cases. On the first episode of UTI, we do an ultrasound of kidney, ureter and bladder. The abnormalities which can be detected are PUJ obstruction and increased post-voidal urine. PUJ obstruction is obstruction at the renal pelvis and ureter junction. On UST, we see dilated pelvis and calyces and a collapsed ureter. On CT, we see again the dilated pelvic calyces, abrupt narrowing at the PUJ and distal dilation of the ureter. DTPA renal scan can also be done. Micturition cystic erythrogram is another major investigation that we can do in pediatric patients. It is only done 2 to 4 weeks after the urinary tract infection has subsided, as it is an invasive procedure and we don't want to do that. It is done to rule out the abnormalities such as vesicourethral reflux and posterior urethral wall obstruction. DMSS scan can also be done to detect renal scarring, but it's only done 4 to 6 months after the UTI has surpassed, as inflammation can also mimic renal scarring. Micturition cystourethrogram, another modality that we use, is done by catheterizing the patient, filling the contrast via the catheter, and then taking images while the filling and voiding phase, also the post-oil film. This helps us detect the vesicoureteral reflux, which we can see here is the reflux of urine back to the upper systems, and posterior urethral wall obstruction. MCU can only detect the posterior urethra, bladder, and the ureters. To visualize the anterior urethral abnormality, we do a retrograde urogram, which is in which the contrast is injected directly via the external urethral meatus. It is done when CT findings are inconclusive and suspected ureter obstruction is seen. Imaging algorithm followed in pregnancy is that we do a USG first. It helps us visualize physiological hydronephrosis, which is present because pregnancy is a progesterone-rich condition and progesterone is a dilator, so the ureters are dilated. USG is safe and non-invasive. If USG is inconclusive or more details are required, we do an MRI, which is second-line investigation. It helps us differentiate between pyelonephritis and hydronephrosis. Last, ionizing radiation. I would like to invite the Department of Medicine to take over.
A very good morning to esteemed dignitaries, respected faculty members, and my dear colleagues. I am Tejaswini Rathod of Batch 2022, and I will be presenting today on the behalf of my team members, Harshit Chaudhary, Lakshya Bansal, Nikki Agarwal, and Archita Binani, on the topic urinary tract infection, under the guidance of Dr. Puneet Andwani sir, Head Professor and Head of Department of General Medicine, and our moderator, Dr. Ambika Tyagi ma'am, Assistant Professor of Department of General Medicine. Today, I will be discussing urinary tract infections with special emphasis on how to clinically differentiate complicated from uncomplicated cases, when to investigate, and how to manage them rationally. Urinary tract infection is one of the most common bacterial infections encountered in general medicine. It can range from a simple lower urinary infection to a severe upper urinary tract infection leading to sepsis if not treated appropriately. It refers to microbial invasion and multiplication anywhere along the urinary tract. Now, clinically, the important thing is not just the infection, but also which part is involved. If infection is limited to the bladder, it causes cystitis, which is usually mild. And if it ascends to the kidney, it can cause pyelonephritis, which can be life-threatening. So, the anatomical level determines the severity of the disease. UTI is broadly divided into uncomplicated and complicated cases. Uncomplicated UTI occurs in an otherwise healthy, non-pregnant female with no structural abnormality and presents with local symptoms only. And complicated UTI is everything else. That is, it occurs in males, in pregnancy, in patients with diabetes, obstruction, in cases of catheterization and stones, which presents with both local and systemic symptoms. Now, why is this classification important? Because uncomplicated infections can be treated with short course therapy orally, whereas complicated infections need longer therapy, sometimes IV antibiotics, and evaluation for underlying cause. Now coming to clinical features of uncomplicated cystitis. Symptoms are located to the lower urinary tract. The classical triad is dysuria, increased frequency, and urgency. There may be suprapubic discomfort, but systemic features like high fever, chills, or flank pain are absent. The absence of systemic toxicity is the key point here. When infection involves the upper tract, that is the kidney, the presentation changes dramatically. High-grade fever with chills suggests bacteremia. Flank pain indicates renal capsule involvement. Nausea and vomiting occur due to systemic inflammation. If severe, the patient may develop hypotension or altered sensorium, which is indicative of urosepsis. So clinically, if both fever and flank pain are present, then it is strongly suggestive of pyelonephritis. Now I will be discussing the complications of urinary tract infections. Complication can be broadly divided into local and systemic. Firstly, coming to local complications. Acute pyelonephritis occurs due to ascending infection from bladder to the kidney. If not treated promptly, it can cause significant renal inflammation. Renal or perinephric abscess refers to localized pus collection within the kidney or the surrounding perinephric tissue. This usually occurs in severe or untreated infections. Then, papillary necrosis is another serious complication, particularly seen in diabetic patients or those with recurrent infections. Now coming to systemic complications. Urosepsis refers to bacteremia originating from the urinary tract, and it can become life-threatening if it progresses rapidly. If severe, it may lead to septic shock characterized by hypotension and multi-organ dysfunction. Therefore, early diagnosis and appropriate treatment are essential to prevent these complications. Further complications include chronic, obstructive, and special situation-related complications. Chronic pyelonephritis occurs due to recurrent or persistent infections. Over time, this leads to renal scarring and progressive loss of renal function. Now coming to obstructive complications. Hydronephrosis may develop due to obstruction in the urinary tract, leading to dilatation of the renal pelvis. Pyelonephrosis refers to accumulation of pus in an obstructed kidney. This is a surgical emergency. If obstruction and infection persist, it can ultimately result in renal failure. Now discussing the special situations. In pregnancy, untreated UTI can lead to complications such as preterm labor and low birth weight. In males, UTI may be associated with prostatitis or epididymoorchitis due to spread of infection. Thus, certain populations require special treatment and prompt attention. Now coming to investigations of UTI. First is urine analysis done by Dept, which is a rapid screening tool. The presence of nitrite suggests gram-negative bacterial infection, whereas leukocyte esterase indicates pyuria. Next is urine microscopy. Significant pyuria means more than 10 WBCs per microliter, and the presence of white cell casts suggests pyelonephritis. Finally, the gold standard is urine culture. As per the cast criteria, more than or equal to 10 to the power 5 colony forming units per milliliter in midstream urine is significant. However, in symptomatic women or catheterized patients, even lower counts can be clinically significant. So, Dept screen test screens, microscopic supports, whereas urine culture confirms. Then coming to imaging. Imaging is not needed for simple cystitis. It is reserved for recurrent UTI, severe infection, or suspicion of obstruction. Ultrasound KUB is first line. CT KUB is more sensitive for stones and emphysematase changes. In children, voiding cystourethrogram is done to detect vesico-urethral reflux. Now management. It has two pillars that are supportive care and antibiotic therapy. In general measures, hydration helps in flushing out the bacteria. Antibiotics are given for comfort, for relieving fever, but antibiotic therapy are mainstay. Now coming to the main treatment, antibiotic therapy for uncomplicated loid UTI, that is cystitis. First line drugs include nitrofurantoin for 5 to 7 days and trimetoprim sulfamethoxazole for 3 days, both having high clinical efficacy. Fosfomycin is given as a single 3-gram dose and is convenient for compliance. Other options include fluoroquinolones and beta-lactams, but fluoroquinolones are usually reserved due to resistance concerns. Most common side effects are gastrointestinal symptoms like nausea, vomiting, and diarrhea with occasional rash. So, in uncomplicated cystitis, we prefer short-course, highly effective oral antibiotics. Now coming to complicated UTI and pyelonephritis. If the patient is severe, hospital admission is required. We start with intravenous antibiotics, commonly ceftriaxone, and often the patient improves. Thereafter, we switch to oral antibiotics. The total duration of treatment is usually 10 to 14 days. Next, in recurrent UTI, the key is to identify and treat the underlying cause, such as stones, obstruction, or diabetes. In females, postcoital prophylaxis must be advised if episodes are related to intercourse. In selected cases, long-term, low-dose antibiotic prophylaxis can be considered. So, complicated UTI requires aggressive treatment, while recurrent UTI requires evaluation and prevention. Then coming to management of UTI during pregnancy. In pregnancy, even asymptomatic bacteria must be treated to prevent complications like pyelonephritis and preterm labor. Safe antibiotics include nitrofurantoin, amoxicillin clavulanate, cefixime, and fosfomycin single dose. However, certain drugs must be avoided. That is, fluoroquinolones due to cartilage damage, tetracyclines due to tooth discoloration and bone growth inhibition, and trimethoprim, especially in the first trimester. The goal is to choose effective drugs that are safe for both mother and fetus. To conclude, UTI is common but potentially serious, especially in pregnancy. Early diagnosis, appropriate antibiotics, and prevention of complications are the key to good outcomes. These are the references that we've used. Thank you.